Hello, thank you for joining today's webinar. On the screen now are the presenters and our team of hosts that will be in the webinar for you today. I'm Kieran Murphy, I'm Clinical Partnerships Manager for Jenx, and my colleague Louise Jenkins is the Product Manager, and she'll be delivering the live demo of the Supine Standard. I'll be providing a presentation of the benefits of supine standing, and just a short informative presentation with some simple tips for supine standing for more complex postures. And then Lou will follow up with the demo, and then we'll have a Q&A section at the end. So if you can save most of your questions for the end, you can pop them in the chat, but we'll have a designated time at the end to answer all the questions. Just a quick overview of who Jenx and Jiraffe are. Jenx is a manufacturer of postural care equipment that distributes postural care equipment for children worldwide, and Jiraffe is the UK distributor of Jenx and Riften products. So, simple overview of the presentation today. We're going to look at the benefits of standing, supported standing in children with physical disability, the clinical and the holistic benefits. We're going to identify some of the typical challenges that might arise in complex postures for standing, with some considerations on how to overcome these challenges, and then keep a focus on the importance of utilising the F word in childhood disability to support our standing frame prescription. So, benefits of supported standing. I'm sure most people in this webinar are well versed on this. Most of us will be clinicians, and we need clinical evidence to support our prescription. And we know that there is evidence within clinical research to support specific body issues, such as improving range of movement, improving bone mineral density. And a large focus of clinical research is focused on addressing these issues, and it's focused from children with cerebral palsy or adults with cerebral palsy quite a lot of the time. So you'll notice that throughout the presentation, a lot of our data and evidence is supported by those with cerebral palsy. And you'll also notice throughout the webinar some infographics and images from Ginny Paleg and her colleagues who do extensive work in showing the clinical benefits of supported standing, and always produce some really, really useful visual guides in their research articles, reports, scoping reviews that can really summarise a lot of difficult data that's difficult to interpret to make it really simple and help us justify our prescription. And all of these resources will be included in the reference list of the slides where we send it after the presentation. In their recent scoping review, they highlighted that bone mineral density and range of motion are the outcomes that are supported by most experimental studies and synthesis. So when we're talking about the kind of highest weighted studies and the highest weighted forms of literature, we're thinking here about maybe randomized controlled trials or systematic reviews. However, it's very difficult to conduct really robust, uniform, gold standard clinical research in children with physical disability, because children with physical disability have their own individual needs and have their own individual prescription. To do gold standard research that requires a degree of uniformity in how we prescribe our therapy and how we address specific needs that just can't be done for children with complex physical needs, and it can't be done ethically. And often there's a requirement to withhold some treatment for a control group. So what this infographic is really useful in showing is that there is quite a large focus on treating bodily issues, and it's a really good infographic that shows that the more experimental studies are focused in bone mineral density and range of movement with a reduced risk of bias in these studies. This is this grey area in the corner. But we are still lacking quite a lot of clinical research in certain areas, and particularly when we move from addressing body functions and structures, or was it those who are more ambulant. So again, things can get a little bit more murky when we're just focusing purely on clinical research, and that is why clinical expertise, opinion and experience is of huge value, such as that of Ginny Paleg and her colleagues, because that helps inform our practice. And in their more recent scoping review, they highlighted that supported standing is not passive for those with the most severe motor difficulties, and that's something that we'll come back to at the end of the presentation and is important to remember. Furthermore, when we're thinking very unilaterally and thinking about addressing specific issues that children with complex physical difficulty might have, then the evidence becomes a little bit more complicated again, because we might be addressing one specific issue such as bone mineral density. And again, a review by Ginny Paleg and her colleagues in 2013 that often we'll use to support our prescription might say prescribe a standing frame to 60 to 90 minutes per day. But if we're only addressing one issue and focused on one issue, are we necessarily treating something that is appropriate for the child and for the carers for their needs? Is a child really focused on their own bone mineral density? Are they focused on their own range of motion? Does it create maybe a negative approach of standing frame prescription that doesn't create something that's fun, interesting, active, that's often more important for the child themselves and their carers? It's about how we prescribe, addressing multitude of issues with children with complex physical postures, and then how we communicate and how we support that to make it engaging and fun. Which is why thinking about the holistic benefits of supported standing is really positive, is really appropriate. And it's very difficult to measure some of these things in robust clinical studies. And a lot of it's covered by qualitative data, such as feedback and interviews from the children and the carers themselves. But often this is the most important thing for the child and their families. And it's this focus and showing how standing frames can provide holistic therapy is really important. And often it's these simple things that are often overlooked because of the pressures of the prescription and the justification of the clinical need for standing frames. What we want to focus on is something holistic in our prescription, and what I really like to use is the F words. As a physiotherapist, naturally I am focused on maintaining postural symmetry and alignment, and always a classic one I think of is trying to maintain hamstring range of movement and utilising standing frames to provide a prolonged stretch to the hamstrings and improve knee extension. But that's very focused in this particular area, which is focused on body structure and function, or in the F words framework, fitness. But what does that mean for the rest of the child's needs? So their functioning and their ability to do things, their participation with their friends, their ability to participate with a family and to do things at home, and how does it make standing fun, and how does that interact into their future and their needs? And that's what we want to do when we're thinking of more complex standing frame prescription in particular. Obviously, for use of any postural care equipment, this is a really useful framework to shift the narrative of we're not just treating those passive structures or those skeletal structures. We're treating a unique individual human being, and we want to make it as engaging and as fun and as childlike as possible. And once again, Ginny Paleg and her colleagues produced some really, really lovely infographics that can sum up evidence in a really, really useful way. And in this one from a more recent study review in 2024, they produced this really, really lovely infographic looking at standing frames and mobility devices and how they interact with the F words, and how we can look at how standing frame prescription really provides holistic therapy for the child and their family. And it has a really useful infographic at the bottom to explain how this research has been conducted, whether it's experimental research or qualitative research, and whether it's case studies. And it's really useful. And I think it's an infographic that can go in clinics anywhere, just help us reinforce how we're doing our prescription and how we're addressing the individual needs of the child. But clearly, there's still things that is a breakdown between a prescription of standing frames and all postural care equipment with ourselves as prescribing therapists and non-prescribing therapists and families. And this is taken from some qualitative research taken in the UK in 2017 by Goodwin and her colleagues, where they conducted a series of interviews looking at the benefits of standing frames. And what this table highlights is that pretty much in agreement as prescribing therapists about what the benefits of standing frames are, and the high percentage, 79%, 75% in terms of positive answers for participation in activities, enjoying activities, and interaction with peers are quite conclusive. But there's then a bit of a discrepancy between non-prescribing professionals and in particular the parent reported benefits, such as participation of activities only 57% agreed with that. And then as we go down further, you can see that enjoying activities, 42%, interaction with peers, 46%. Now, these, in my opinion, should be the easiest things for us to facilitate and show to families and to children. Once we've addressed how to support and stand safely and appropriately, it shouldn't be difficult to show how a stander can help with interaction, can help with making things fun, can help with increasing physical activity. And is it these simple things that we often miss in our prescription, like I say, due to the pressures of addressing physical need and justifying prescription? And we want to not forget that as part of the process. And what's really important is how we communicate, simple tips for communication, because children with complex postures often find standing more painful, more difficult, find it a challenging task, and we want to reduce that experience by showing simple things in terms of the benefits of the standing frame, but also encouraging their engagement or carers' engagement, and that's whether it's carers at home or at school, with the process, to show that actually standing can be fun, it can be enjoyable. And one thing that's often stressed through these reviews is that the child has a voice and has a choice, something as simple as the child chosen the colour of the standing frame, just to make it a bit more of theirs and about them, a bit more individual, rather than something that's prescribed for them. Have they had choice in where they stand and how they stand? Does it have to be 60 minutes a day for a certain time of day? Can it be structured across the day, a few times a day, or can it be at different times that the child chooses or the family chooses? Simple things like that are often overlooked. And again, have we provided an engaging assessment? Have we focused when we're prescribing purely on the posture and accommodating or correcting posture? Or have we done something where we've got the child up safely and standing and show them how they can play and interact with the world once they're up in standing, just to improve that engagement, improve that experience with them? So let's go to complex postures. Simple definition of complex postures might be atypical positions that occur from underlying medical conditions. And the postures can lead to a range of complications such as spinal deformities, rotational deformities, leg length discrepancies and contractures. And these are some of the things that we'll discuss as part of the webinar in terms of considerations for standing. And what we know from research and from this slide is that complex postures are associated with immobility, more severe motor disorders, and increasing age. And so it's important to bear this in mind, that we're thinking about those children with a more severe motor need, or those older children where these more complex postures may occur. And do we try and address these issues early as possible, or do we need to consider at later ages in life a different type of standing frame or a more complex standing frame to maintain standing? And these goals shift and change throughout the child's life, and that's why we do constant reviews, monitoring, and interplay between ourselves and the carers and a multidisciplinary team. So this is why we might focus on supine standing frames, which is going to be more of the focus of the demo in this webinar, because supine standing frames are generally a more supportive way of standing. They generally offer more support from head level down and offer more features for deformity and contracture, and often require more of a mechanical hoist for support. And we can use supine standing frames to assist with more severe motor control. What's also important to bear in mind is that supine standing frames are maybe one specific position of a standing frame. Multi-position frames can offer supine standing. There's a wide variety of different standing frames on the market. We've got sit-to-stand standing frames, as well as another example, we've got dynamic standing frames. So we're just talking really about one specific type in this webinar, but supine positioning in itself, about the considerations, whether it's with a supine stander or whether it's a multi-position stander. And what we have to acknowledge is that complex postures often go hand in hand with medical complexity. And this is where MDT collaboration is extremely important for successful prescription engagement. I'm often with seeing more and more children with more complex physical needs standing and standing longer and standing for more years, because we've had such advancements in technology with equipment, we've had advancements in treatment, we've had advance and awareness in postural care for the 24-hour period. But what that brings with it is the more complex medical needs. And I will often liaise with, say, the complex needs nurse around the child's current pain levels and how we're managing that. I might liaise with orthopedics and the spinal teams regarding weight bearing status, current bone mineral density, what their current goals are, and whether we can affect that or improve that with standing frames. I might liaise with speech and language teams, and we have a local charity in Manchester area called the ACE Centre that provide augmentative communication, and speak to these teams about how they're utilising communication strategies within their seating systems, and how can we include that within the standing frames. Maybe it's liaising with the respiratory team around appropriate positioning and ensuring effective ventilation when in standing, and appropriate positioning of the trunk and the head. And this is where it's really important that supine standing frames and complex physical postures have this multidisciplinary approach to improve successful outcomes. So there's so many factors to consider, and this isn't just for supine standing frames, but we need to think about a myriad of things when we're prescribing, and it can seem quite a lot, but this is where taking time and linking in with multiple professionals can make this as successful as possible. Obviously, we've said increased age is often associated with more severe postures in those with more immobility. If actually we're prescribing a standing frame at the earliest point to typical development, say around 9 to 12 months, do we need to have a supine standing frame? Can we do something maybe that is multi-position, that can provide more experience of different postures, and actually maybe we can try and reduce the incidence of the complex posture arising as the child grows older. And we need to think about the level of control of the child. Often children go into a supine standing frame because of manual handling needs, or maybe because of severe contractions in lower limb, but they don't actually need a huge amount of support in trunk and around the head. So can we make it as active as possible? Can we provide support at the appropriate level of activity to make standing a physical activity and something that can develop skill further? Obviously, we've talked about age and growth and how much can the standing frame grow with the child to provide continued experience and provide that constant reassuring feeling of having the same standard and not having to chop and change through standards as they grow over the years. And obviously, as I've stressed at the start, thinking about the F words, so we're prescribing it more holistically and more child-centred. So having a little think about some of the common physical issues that we may encounter in complex physical postures, and we're just going to talk about maybe some tips and some things to consider when you are prescribing a standing frame. So lower limb contractures and reduced range of motion. We've got a lovely visual picture here from a research study taken in 2020 of a young boy who stopped standing for a good number of years, started standing again, and progressively they increased the stretch through his lower limbs, increased the inclination of the stander, and as you can see, particularly around his hip flexors, they managed to improve range of movement. And we've seen various instances of this in clinical research, that actually we can positively influence range of motion in standing and provide a sustained stretch that can provide short-term and even further, as in this case, more longer-term outcomes that may have positive impacts on quality of life and health. What we need to consider is actually, is it a true contracture, or actually is the range of motion maybe affected by things like tone and spasticity? A true contracture, we're going to have to accommodate more, and we're going to have to think about how we position support around the standing frame to accommodate that. But if it's maybe influenced by tone, spasticity, can we provide a sustained stretch to improve range of motion? And that brings into dosage. Obviously, that previous slide, they had different dosage levels for influencing spasticity and tone. So do we prescribe around that dosage to positively affect it? We want to think about, what does the standard provide? Does it provide depth adjustable supports, such as in this picture here, that can meet where the contractures are around the hips, around the knees? Do they have individual components and leg channels so we can support at the knee, support at the hip, support at the feet? Is there any derotational supports or features to the standing frame? Because often with contractures, we're not just moving in one plane. We think about children with a scissoring gait. How can we do some adjustments in the standing frame to derotate those legs, to bring them into a more neutral and more symmetrical and a better position for weight bearing? And of course, thinking about, again, working within the MDT, I'll often work with the orthotic team. So standing frames will often have features to provide adjustment at the foot plates to accommodate maybe some contractures at the hip and knee. But actually, if we've got appropriate AFOs, or if we've got appropriate footwear, or even gaiters for the knees that can help distribute the force along the lower limb. Can we use the orthotics in combination with the standing frame to accommodate contractures or provide a stretch? Another issue we highlighted earlier was leg length discrepancy. It's quite a common issue that we come across as therapists prescribing for standing. And things that we've got to question first is, where is the discrepancy coming from? Is it from a contracture at one of the joints? Is it from hip displacement? Is the discrepancy fixed or flexible? Can we actually level out the discrepancy in standing? It might come from maybe some tone around the trunk and around the obliques, and actually in standing we can use gravity positively to level out that pelvis and level out those lower limbs that might be more apparent in sitting or in lying in particular, and actually we don't need to accommodate the discrepancy in standing. Furthermore, it might be less apparent in standing that there's a discrepancy from a true leg length discrepancy, because gravity levels out the feet and levels out the lower limbs. But then we might get tilting at the pelvis or a bit of a flexible scoliosis posture. So actually, do we need to accommodate that leg length discrepancy through features like individual channels to positively influence the pelvis and the spine? And again, it's important to liaise with orthotics teams to provide appropriate footwear AFOs that might actually be able to be prescribed to level out the feet, level out the pelvis, and then we maybe not need those more complex features on the standing frame. But again, individual knee, pelvic, foot supports are really important, and individual leg channels can be really important to provide individualized prescription for those lower limbs. Reduced head control is quite a complex area, and particularly the ones that I find difficulty with standing is those low tone head postures that flop forward, or those dystonic postures that often rotate and side flex to the side. And I think it's more difficult in standing because the options for headrest positioning is often a little bit more limited than, say, in the wheelchair or in the seating system, where there might be more standard brackets or standard mounts. But what we need to remember is that the head is the last thing that we should be addressing. We should hopefully influence the head control positively with appropriate supports at feet, at pelvis, at trunk, and hopefully that can reduce any abnormal posturing through the head. If we feel that we've appropriately supported lower and at the appropriate levels, then we need to consider some things about how we can appropriately support the head through the features of the standing frame. One nice feature for the lower tone head postures is having a swan neck type mount that can reach up, down and round and really support the occiput, and in combination with gravity can try and keep the head in midline. But then in that case, often we're reclined backwards, so then we need to think about visual field and how we can make standing still interesting, interactive, that the child isn't just looking up at the ceiling. Can we make some adjustments to the tray? Have they got any AAC devices on some stands that can be brought into the standing frame so they can interact with that? Can we actually progressively increase the standing status from a recline position into upright to develop skill? And actually, we can use that as a challenging aid for developing head control over time. For some postures that are maybe asymmetric, and in those dystonic postures, have we got an adjustable headrest where we can try and bring the head into midline or accommodate that posture by setting the headrest asymmetrically? And one thing I'd encourage is inter-brand work. Like I say, my experience is that it gets quite difficult for head positioning for the more complex postures because of difficulties with standard mounting. But I've worked really well cross-band as a therapist to see actually does the company provide a mount that will accommodate other different type of brands, because there are so many different types of headrests on the market. And can we work together co-brands to provide the most optimal solution for the child? Rotational deformities are often quite common in complex postures. We know that particularly these children spend a lot of time in supine, and distortions come from gravity, from unstable surfaces, from tone. So we get windsweeping postures, we get rotation of the chest, we get rotation of the pelvis. Again, it's important to address whether this is fixed or flexible, and this can be quite easily assessed in a supine standing frame where we're de-rotating the body along with the help of gravity along the axis of the body, so we can get a good idea of what is maybe fixed or flexible as we're getting him into the standing frame. We want to think about adjustments that may help with derotation, such as different types of chest harnesses offering different types of pull to potentially reduce any rotation or accommodate rotation. Can the laterals provide rotation and support at the pelvis and at the chest? Do they move multiplanar because it's a multiplanar movement? Can we do that to accommodate or correct? And again, multi-adjustable lower limb support, so support pelvis, knee, and foot, as well as a multi-adjustable headrest can be important. And in particular, going hand in hand with rotational deformity, scoliosis is something that I'm seeing more and more because we're seeing children with more severe posture standing for longer. But a challenge that I often find is that these children are not necessarily growing upwards, they're growing down and to the side, which can be quite a difficult thing to manage and address in a standing frame. Particularly modular standing frames, it can be quite difficult. An issue I'll find is that we're having to compress the trunk pad down to meet the shoulders, but then we're getting clashing of the pelvic pad, and then that affects the headrest, not able to get the headrest up and over because we're getting a big gap between the trunk pad. So there's many things that maybe we need to think about that. Again, similar things to the rotational deformities such as the chest harness and rotational laterals, and can you set things asymmetrically for this child here? If his posture is a little bit more fixed, we might need a smaller lateral where there's the concavity, but can we provide a bigger lateral on the convexity, and can we try and just manipulate that posture a little bit more just to bring a little bit into midline? We'd have to set asymmetrically to try and do that. Can the standing frame allow that? One thing that I've seen that's really positively work is using accessories to build around the child's posture. So we're not working on a modular frame where you have to meet different points and you're getting flashing. Actually having something there where you can place your accessories pretty much wherever you want and build around the child's posture has worked really well for me. And I've seen some really, really positive changes in children with quite marked scoliosis in more supine, kind of flat standing frame that actually has options to build around the user. Another thing to think about is the risk factors for scoliosis and things that we might address for that. So this is a really useful predictor for scoliosis that was taken from a study in 2020, identifying risk factors for scoliosis, and 4 of the main predictors: female sex, GMFCS levels 4 and 5, epilepsy, and limited knee extension. So going hand in hand with the scoliosis, what are we doing to address those lower limb contractures that actually might influence and might cause further progression of the curvature in the future? What is the standing frame offering to try and maintain or improve the limited knee extension? And I just want to highlight, just going along with that, a brilliant little video of 2 sisters, Mariam and Day, who are conjoined twins, who have been using one of the Jenx standing frames to access standing, physical activity and play since they were age of 4. It's a perfect example of using a standing frame that needs to be smaller, a little bit wider due to their shorter squatter posture. It needs individual components to be placed around their unique posture. They initially needed individual leg length discrepancy. And it's a great kind of summary of what I've just been saying regarding more complex postures and scoliosis. This is a picture of Mariam and Day when they were around 4 years of age, and this was a couple of months ago. And this is taken from a brilliant documentary called Inseparable Sisters. So if you've got half an hour after today's webinar, I encourage you to watch that documentary, see the incredible work that the therapy teams are doing, the incredible work that the school is doing and the father is doing to get them as active as possible and integrating with the world around them. So that was Mariam and Day. I love that video. I love that documentary. And it's just a brilliant, beautiful example of collaboration between family, therapy team and school. They've worked really hard to find an appropriate standing frame for quite a complex posture and providing them experience and opportunity of different types of movement and posture. I'm going to quickly fly through these slides because I've overrun as always, but I just wanted to stress that because we're using supine standing frames most often for more complex postures, it doesn't mean that supine standing is passive. more for these children that are more immobile and more severe motor difficulties. Actually, studies are suggesting that changing the child's position in supported standing accumulates light activity, increases heart rate, influences muscle activity, and breaks the sedentary barrier threshold, which is important because we're having this shift on focus on 24-hour movement and the importance of reducing sedentary behaviour in children that are often spending 95-96% of their day being sedentary. And it's quite difficult to do moderate to vigorous exercise. So how do we break down sedentary behaviour through lots of light physical activity? Regular standing may be one. And then making regular standing really active and engaging can be really important. So once we've supported those children and got them safely standing, what can we do to make it active, make it fun? Can it be things like just simply adding a bowl to the tray so we can do midline play? There's a tray of anything where we can attach toys to, attach communication devices. Can we reduce the support really easily through tool-free adjustments just to try and challenge skill and make them work a little bit harder? Simple things like that can be important as standing frame use progresses for these children. And what I want to highlight is that carers and family often have the best ideas, such as Zeke's mum has created a brilliant swing ball game for him here in his standing frame. So just to summarise, supine standing is often that offers more complex features to support more complex postures, and individual prescription is extremely important. I know sometimes we're tied down to funding and time down to resources, but trying to provide individual prescription is really important. Supine standing doesn't mean passive, and once we prescribe the standing frame, how do we show that it can be fun, active? Can we keep going back and reviewing it so it can be more engaging for the child? And always think F words in our prescription. I'm going to hand over to my colleague Louise now, who's going to do a demo of the supine stander by Jenx.
Hello everybody, my name is Louise. As Kieran said at the beginning, I'm Product Manager here at Jenx. Before I took this role, I used to be out on the road as a product advisor, so I've got lots of children in this standing frame. This is the Jenx supine stander size 3. It's come in a size 1 and a size 2 also. Here's in the size 3 to demonstrate to everybody because it's the largest one, so it's easier hopefully for you to see on the camera all the features. Most of the features are the same for the 1, 2 and the 3. There might be some slight variations, but in general, it's going to be very similar. As you can see, this is in blue. It does come in a variety of different colours, pink, green. I have put children in Spider-Man Supine 3 before, so blue frame, red accessories. We've done black and pink and rainbow and all sorts. So just a quick look at sort of the boards and the electrics in the frame, and then I'm going to build up the frame as if we were doing an assessment. So the boards are PU. They are polyurethane. They are slightly squidgy, completely wipe clean and impervious to fluids. So when Kieran was talking earlier about the different benefits, holistic benefits of standing, one of those is obviously getting your bowel movements going. So this is great for being able to clean that down afterwards. And again, with wanting to do individual prescriptions, obviously that's the ideal. We can't always do that. This is a great frame for sharing. Partly because you can wipe it clean, but also, I don't know if you can see it on the camera, but the sections on the PU here are numbered. So it's quite easy to swap and change the accessories over, and it's completely tool-free to do that. So that's just a little bit about the boards. The boards on the top do come off. You probably saw in one of the videos there that the standing frame looked a lot shorter. So I'm not going to do it on this demo, but you can just unscrew at the back here and lift off the boards to make it come down much shorter. And then if you want to grow it to its full extent, if you pop a headrest up here on the top, you can hopefully see that it does get quite large, sort of 6 foot plus, really. So the electrics, just a quick look at those. You've got your handset. This is a bespoke sort of handset for Jenx that we had programmed for us. Can you see on the film there? You've got your battery indicator. So it's really easy to see straight away how much battery you've got left. Right, sorry. So battery, you can see the battery on here. So you know before you stand your child up in the frame how much battery you've got. There's a couple of safety features in here as well. So if you haven't got enough battery left in the system to go fully vertical and then back horizontal again, it will not let you come up to standing. And that's really great if you've got a heavier, taller person in the frame. You don't want to be stuck up in the standing position and no way of getting them out there. If that does happen for some reason, you can plug this into the mains and use it while it's plugged in. So some good features there. The frame itself is on a solid metal base on 4 swivel casters, so it's quite easy to move around for a big frame. Individual brakes on each caster. Quick look at the foot plates, and then we'll do the sort of mock setup. These foot plates are both height adjustable and angle adjustable individually, so we can accommodate for leg length discrepancy and flexion there in the foot plates. You can see, hopefully, if I do that, the angle is changing. We've got our sandals mounted onto here. If I loosen one of those off, you can hopefully see we've got quite a lot of range in those. We can angle them, move them in and out, create a bit of abduction. Lots of things we can do there. These do come in different sizes, so there's a selection available. So, okay, just going to lay the board flat because it's much easier to put the accessories on. Hopefully you can see on the video, it's quite a nice, slow, gentle movement there. If anybody hasn't ever had a chance to stand in a supine standing frame, I would highly recommend it. It's quite a strange experience, actually. It often feels like you've gone further back or further forward than you actually have. It's worth doing just to get a feel for what it actually feels like. Okay. So, just going to work sort of bottom upwards. Start with the knees. There's various different sizes and styles of knee supports and knee straps. These are our knee flexion supports. You can build this standing frame around the child really easily. One of the nice things about this frame is because it is a solid base of support you can hoist on. As long as you've still got the sling in place for safety, you can then kind of just lay your child on here and build up around them. So you don't have to rush, you don't have to adjust anything, you don't have to measure necessarily to get anything correct to do that. All we're going to do, imagine there's some knees here, is slide in the support into one of these slots. You have got some height adjustment on the actual bracketry as well. So if you can't get it perfect, you can move it side to side, and you've got a bit of angle adjustment there also. And hopefully you can see that we can accommodate quite wide and quite narrow shapes here. So you're just then going to clamp down underneath using the wing knobs. Again, completely tool free for that part. Go, and then we'll have a look at the straps. So this is one of our X straps that's designed to go either side of the knee there. So you're going to get this nice and tight around the knee, like so. And then you're going to pull, I don't know if you can fasten this a little bit, Chris. You pull that there and tighten on like so. And what you can do with these is, this is actually 2 separate straps. So if you separate those, again, you have to imagine there's a knee in here. It's quite difficult. It'd be easier for me to show if I had a person. But you pull on the grey strap, and this knee cuff is going to rotate like that. And if you pull on the black strap, it's going to rotate the opposite way. So you can control a lot of rotation there. Once you've got that exactly where you want it, clamp those two Velcro straps together and secure on the side of the pad there. I'll quickly pop the other pad on just so you can see what it looks like. Finish. Very quickly. There we go. Yeah. Once you've got your positioning correct, you can clamp put those two together there. You've probably noticed underneath we've got these arch frame pads. These are just to support the knee if you are accommodating for any flexion. Then Velcro on underneath, like so, and then we can build those up if needed with a number of PU pads there. Another option we've got for the size 3 standing frame is the abduction block. This is really nice because it can slot in at any point during the assessment. It just slides in like so and then clamps down at the top here. So you can take that off for your transfers quite easily. And we do have the option as well with this Velcro on the sides to pad that out with various different bits of padding if needed. Okay, moving on up to the pelvis. The positioning blocks here for the pelvis, again, they come in different sizes. These are the XL. They clamp on in the same way as the knee blocks. So you're going to slide them in, clamp them underneath. What's really nice about these is the straps are not fastened necessarily to the side of the pad here. So they're independent almost of the pad. So you can get a really nice fit here. And then you can pull on the external part of the Velcro there and tighten in sort of one side. So you can get a good control there of any sort of rotation or obliquity. Another nice thing about this is because it's a solid base and we're not in a hurry to get all the supports on really fast, you have got a bit of time here to let gravity help you with a bit of a stretch and a bit of a kind of relax before you make all of your fine-tuning positional supports. And then once you've got that where you want it to be, again, it's just a clip at the top. Tighten, nice and secure. Okay, so laterals. You can use blocks for the laterals if you want to. We tend to use the flexible thoracics up there. So again, exactly the same process with the brackets. You're going to slide that on there, clamp it in the right position, and then you've got the same style of strap. What you're going to get here is your hugging motion when you come through there like that. Just want to sort of point out as well, as Kieran was saying in the presentation about offering different supports for different shapes of the body. You can offset the laterals, or you could use smaller laterals at different sides, like so. That would work also. So you get a bit of an offset there for scoliosis, or different sizes for different body shapes. Either would be fine. I will just pop the other side on just so you get an idea of what these look like when they're on. Oh. Okay. Again, it's a bit difficult to see without a person in there, but hopefully you get the idea. I'm going to bring the frame back up now. And again, like I say, it's nice and smooth and slow. I need to fill this space. Okay, that'll do. We also have the option to add a harness to the supine standard frame. So again, you get the idea. You've got a harness in there. You've got lots of different attachment points and different ways of attaching on the back to make this fit basically wherever you need it to fit. Head support. You've got the standard kind of flat headrests that you see on here, and as I mentioned in the webinar, we've got the swan neck on most of our head supports. We'll have the swan neck bracket like that. So if you need something more complex, we can do the same thing with the multi-grip head support. I could probably talk for 20 minutes just about the multi-grip, so you'll have to look that one up on the YouTube page, but that's a really good option if you're wanting to mount a head support. And with being able to move the boards away, you can mount that right down here if you need to. If you don't need that much support, we do also offer the head pad, which I'm not going to put on because I have to Velcro it all, but that would just sit there like so if you needed that. So now we're up and we're standing, and that's great. We want to be able to do something. It's so fun. So we've got the tray, and we have to move this bracket up. We'll drop it down. So the tray will slide into the bracket there. As you can see from my fumbling movement, you can move the tray bracket up and down. You can also angle the tray. You can have it with a flat base here to do any kind of thing on there that you need. And then also this will come off, like so. And we can add a bowl into this here. So any messy clay that we want to do, we can do that with the tray there. And that is a really quick whistle stop tour of the Jenx Supine 3.
After the webinar today, I'm just going to show you the slides again. So we will send the PDF slides through to you